Hello, welcome to the OncoPharmaBrain YouTube channel. Today we will be discussing Tucatinib, a new treatment option for HER2-positive breast cancer. In this video, we'll take a deep dive into everything from Tucatinib's unique mechanism of action and the results of the pivotal HER2-CLIMB trial to the drug-drug interactions you need to be most aware of in clinical practice.
Let's start with a quick review of our target, HER2. As shown in the diagram on the right, in HER2-positive breast cancer cells, the amplification of the HER2 gene leads to an overexpression of HER2 receptors on the cell surface. This creates a state where excessive growth signals are constantly being sent to the cancer cells. Tucatinib is a small molecule compound that targets these HE2 receptors. Its most defining feature is that it binds highly selectively to the ATP binding pocket located within the intracellular domain of the HE2 receptor. This high selectivity is one of Tucatinib's greatest strengths. This characteristic of binding intracellularly has significant implications when combined with other therapies. Anti-HER2 antibodies like trastuzumab, as well as antibody-drug conjugates, ADCs, act from the outside of the cell. By combining these with Tucatinib, we can achieve a dual blockade from both the outside and inside of the cell, leading to a powerful synergistic effect. To summarize, Tucatinib selectively binds to the ATP binding site of HER2, blocking the intracellular activation of the MAPK and PI3K pathways, which are involved in cancer proliferation. Because of this, it is designed to deliver a stronger anti-tumor effect when paired with existing anti-HER2 therapies. Now, let's look at the overview of the Phase 3 HER2-CLIMB trial, which demonstrated this efficacy. This trial evaluated the efficacy and safety of adding Tucatinib to the treatment regimen of patients with HER2-positive metastatic breast cancer who had already received multiple prior anti-HER2 therapies. Patient baseline characteristics are crucial for interpreting the results of this trial. Not only were there many heavily pretreated patients with a median of 4 prior lines of therapy, but remarkably, nearly half of the cohort, 47.5%, had active brain metastases. Conducting a trial with such a high inclusion of brain metastases cases makes it a groundbreaking study that closely reflects real-world clinical practice. Here are the results for the primary endpoint, progression-free survival, or PFS. The Tucatinib combination group, represented by the blue line, reduced the risk of disease progression or death by 46% compared to the placebo group. With a hazard ratio of 0.54, a statistically significant prolongation of PFS was clearly demonstrated. Furthermore, excellent results were shown for the secondary endpoint, overall survival, OS. The Tucatinib combination group reduced the risk of death by 34% compared to the placebo group, with a hazard ratio of 0.66, confirming a significant extension in overall survival. The strength of this effect is also evident in the subgroup analyses. Efficacy was observed regardless of hormone receptor status or age. But what is particularly noteworthy is the consistent PFS improvement in the Tucatinib combination group, regardless of the presence or absence of brain metastases. This data represents a beacon of hope for many patients struggling with brain metastases. On the flip side, we must also review its safety and side effect profile. The most commonly reported adverse events in the Tucatinib group were diarrhea, hand-foot syndrome, and nausea. However, the majority of these events were mild to moderate at grade 1 or 2, suggesting a manageable safety profile with proper interventions like dose interruptions or reductions. Now let's discuss something you absolutely must know when using Tucatinib in clinical practice: drug-drug interactions. Tucatinib potently inhibits the activity of CYP3A, a metabolic enzyme in the liver, as well as PGP, P-glycoprotein, which acts as a drug transporter. This creates a risk where co-administered drugs are not properly metabolized or excreted, causing them to accumulate in the body. Let's look at the actual data. This graph shows the blood concentration of midazolam, a typical drug metabolized by CYP3A, when taken alone, the blue dotted line, versus when taken with Tucatinib, the red solid line. You can see at a glance that when combined with Tucatinib, midazolam blood levels spike dramatically, and the time it takes to be eliminated from the body is significantly delayed. Comparing the pharmacokinetic parameters highlights the magnitude of this impact even further. Co-administration with Tucatinib increased midazolam's AUC, indicating total exposure, by a staggering 5.7 times, and its Cmax, maximum blood concentration, by 3.0 times. This data clearly demonstrates just how potent of a CYP3A inhibitor Tucatinib really is. Because of this strong metabolic inhibition, there are numerous drugs that are strictly contraindicated for concurrent use with Tucatinib. For example, this includes certain anti-cancer drugs, immunosuppressants, sleep medications like Belsomra and Halcyon, and some antipsychotics. Their blood concentrations could rapidly spike and cause severe side effects, so they must never be used together. Caution is also required with cardiovascular medications. Anticoagulants like Xarelto, certain antiarrhythmics, and some calcium channel blockers used to lower blood pressure are also contraindicated. Since it's not uncommon, especially for elderly patients, to be prescribed these medications by other specialists, a thorough medication review is absolutely essential. Furthermore, certain drugs for dyslipidemia and ED treatments are also contraindicated. Tucatinib possesses inhibitory effects not only on CYP3A, but also on CYP2C8 and PGP. When prescribing, please be sure to meticulously check the patient's medication record and always verify the safety of concomitant drugs using the latest prescribing information. And that brings us to the end. While Tucatinib is an outstanding drug with high expected efficacy, even for challenging cases of HER2-positive breast cancer with brain metastases, it also requires strict management of its potent drug-drug interactions. We hope today's explanation serves as a helpful guide for safe and effective daily clinical practice. Thank you for watching until the end, and please consider subscribing to the channel if you found this video helpful.